I think this is a very good opportunity. Even, I have been learning a lot. I have been listening to Dr. Handu and Shruti for n number of times, but still, I learned a lot today. That means it's a learning opportunity for all of us. I think we all are trying to explore this thing for the benefit of our patients. So epitope matching, in the interest of time, I will go into this thing in topic per se. It's actually, this is, I've tried to put it in a practical way as well as in a theoretical way, because everything cannot be extrapolated into our clinical practice. But there are areas where we can take some cue from this concept. This is where, just like Neeraja madam told, the NGS high resolution typing, and what Dr. Shruti told, the solid phase Luminex platform antibody analysis, they collude, collide, and merge. So this is the matching, the epitope matching is, I would say, is just like renal transplantation. We think that we are almost there, but it just evades us. So the HLA is the protein, MS is the gene. The HLA protein that we see on the cells, it is nothing but a series of amino acids. So in this series of amino acids, this chain of amino acids, there are hotspots, or there are islands of increased activity, or that gives the antigenicity of that particular molecule. So it is what these immune cells look into. When it sees an HLA, what it looks exactly is to know which is the epitope that it has and how to react against that. And in my talk, this epitope and eplet, I'm taking the synonyms for the simplicity of it. So this is how HLA molecule is like. You have the topmost sequence like A01 is the consensus sequence, and all the sequences that are listed below for different HLA alleles, you have this where the amino acid differs. Okay, so HLA, just like we discussed in the morning, Dr. Neeraja mentioned that it is a highly polymorphic molecule, but there is a lot of homology within this HLA molecule as well. So this is an HLA. So what happens is that there are areas, there are hotspots which gives that specific immunogenicity. That is what we call as the epitopes. And those epitopes that line the antigen binding group is more important rather than certain epitopes that lie far away from the antigen binding group. So now we have to just detach ourselves. So we have been discussing about HLA match, mismatch. You have 2 A's, 2 B's, and 2 DRs, each from our parents. Now you just disconnect. Just imagine your HLA system is made up of certain epitopes. Okay, these epitopes are just different characters. So now what we are comparing is you have a donor. So just like you look for an antigen mismatch, now we are looking at an epitope mismatch. We are looking at what are the characters or the epitopes that are there in the donor that is not in me. So this is the very fundamental concept of epitope matching, but it is easier said than done. So we have an epitope registry. So people have analyzed by using monoclonal antibodies and serum association studies. They have identified, and this is something, it's a free site. You can just log on to HLA eplet registry, and you can see that this is they have all, it has been updated. Then even when I opened this is a screenshot I took yesterday night. So they have an update even on this first week of July. So this is in the 44th position of amino acid. The changes. It just see what all antigens are being depicted. So this is it. So it's a complex language, but we'll see how we can use it. So epitope, this is something, it is in the HLA. The HLA has been evolving all this the last 50, 70 years. So this has been there, but our understanding about the epitope has been different over the time. So it has got a significant past, and now we are using it in a different context. And there is a future which we think might be good, or we don't know whether it is a hype. So this is the old, in 1960s, there are two pioneer HLA labs. One is Professor Terasaki lab in UCLA, and the next is Dr. Van Root's lab in University of Leiden, Netherlands. They both came up with, they noticed that there are certain sera cross-reacted with certain group of antigens, okay? And they called it as cross-reactive groups. This was mainly identified in HLA class 1, A and B. So now we have these old correct sheets. It is still very relevant today, you know. So if you have a group of anti-A antibodies, ideally what we should do is that we should have printouts of this and see whether it is falling into some correct. So that is a very meaningful information for us. So similarly, you have a B correct group, and this BW4 and BW6 is nothing but just another public epitope, which is so all B antigens, HLA-B, will either have a BW4 cap or a BW6 cap. And certain A's have, BW4 and certain C's have BW6. So this is just like this, you know, this is like two soccer teams, one having one jersey and one having another jersey. Suppose I develop an antibody against that BW4 epitope, then what happens is that bunch of B antigens that harnesses the BW4 epitope is hostile to me. So I will show certain patterns. So this is something, you know, you have a HLA antibody analysis in a SAP printout coming like this thing. Now, when you look at a steep of a high-rise building in the middle of the road. You know, there are a lot of. So what should interest us is that whether it forms, some epitope can be accounted for this reactivity. So when you put the same image that I had, you know, when I extrapolate into, I take a correct sheet and I put each antibody, everything is falling into A2 correct. Okay, so I cannot. So suppose I have a donor, you know, with a very low MFI might be, but from the A2 correct, it's better that I avoid it, because, you know, so that gives a little more clarity in selecting my patient. So this is another group. Usually we don't do HLA-C typing, okay? So we get, you know, many of these C antibodies pop up, okay? And we just ignore it, and we just look at the MFIs, everything is less than 1000 B. But the overall pattern was a BW6 pattern. So the take-home message is, the pattern is very informative. Okay, so it need not be that you have patterns everywhere, but you have to search out for a pattern, look out for a pattern, and if you have a pattern, then, you know, it is some common trigger that is eliciting this immune response, and that's what we call like epitopes. So this is the HLA-BW4 pattern. So you can see, you know, so the one with the least MFI, you know, BW4, it is just 2000 MFI. So if I keep an arbitrary cutoff, and I take that B52 guy, you know, I might be in trouble, because the pattern is more important. Okay, so I have an antibody against that HLA-BW4, which accounts for this amount. So if you get a pattern driven by an epitope pattern, that gets this thing. Now HLA-C antibodies, again you have epitopes identified it, and C usually come in groups. You know, you cannot ignore it. Huh? And HLA-DP, again, there are like 4 or 5 epitope patterns that have been identified. This is one case, you know, this is a 84DAV epitope pattern. So everything is basically that deep. So that's a significant DP antibody. You know, you're getting 1 DP or 2 DP, and having a block like this thing falling in the epitope pattern has entirely 2 different information that we have. So this is a whole list. You can see it in online. So people have looked at it. You know, way back in 1980s, early 1980s, Rodi, he looked at, you know, all the sensitized patients, HLA, he ran, and he found that even at that, with the correct data that we had that time, he found that 85% of the patients who had antibodies had some correct pattern to be attributed to. Then subsequently, people in US and people in Europe had tried to look at their data and see that whether the correct matching had improved outcome. But unfortunately, both papers did not prove anything, because they already had some sort of existing matching mechanism, you know, AB, DR full match kidneys and DR matching systems already incorporated in the already present allocation system, that they could not tease out the advantages of correct systems in the previous papers. So from the past, what we can infer is the idea of correct, that there's a shared epitopes, and the reactivity pattern is something that we had information from the past. And on an individual level, you know, I know that A2 correct, I have a donor from that A2 correct, I will try to avoid that donor from that correct. So on an individual level, we had data that this patient might have a benefit, but on a population based on allocation level, we did not have enough information at that time. Now coming to the current use of epitope is that now as a clinician, the thing that we have is that we are transplanting a lot of sensitized patients, and we are now looking at allograft survival beyond like 10 years, 15 years, 20 years. That's what we aim like. So the priority of the clinicians have changed. And similarly, in the molecular phase, in the HLA labs front, what has happened that you have now almost all typing is molecular typing. It's now like SSO, SSSP, or it's NGS. That's the way that we are right now. And the 3D structure of HLA molecules are available right now. So both these things help. This gentleman, Professor René Decos, now he was the torchbearer of this concept. In 2002, he put all this epitope data into a software and what is called as HLA matchmaker, and did a lot of retrospective studies. And even if you critically look at HLA epitope data, almost all are only retrospective studies. Okay, so basically a lot of tools came subsequently. So the yellow one is suppose it is an antigen. So B cell is an antigen presenting cell. The B cell identifies those epitopes in the antigen. That is called the B cell epitope. Okay, and it processes and presents it to the T cell, and the T cell identified that part of the antigen that is called as the T cell epitope. So people worked on different epitopes. So the thing is that there are people who have worked on B cell epitope. Professor Bakasnoi worked on B cell epitope. There are other groups working on other groups. So different people have come up with different software tools or computer algorithms. And HLA matchmaker, as I mentioned, was based on that. Now the Cambridge group had they had some sort of fine tuning into the B cell epitopes. Then this is from Germany, Perch group. They have identified the T cell. All these things is almost freely available. First, for a trial basis, you can do it, but otherwise, it's something that you have to pay. HLA-MI is again free. It's from University of Leiden. They have looked at the amino acids as a whole. So this is a evolving phase, or is a new language being we have to learn it. So this is out there, but how much we can use it is something let us see. So the thing is that limitation is that everything is almost pretty much standardized for high resolution 4-digit typing. We need 2-field typing for that. So what can we do? We can do it at an individual level, okay? Just like the previous scenario, it's more of qualitative. You look at which all epitopes are acting, and you can take a decision on your patient and the donor. And second is on in a bigger cohorts like multi-centers or single center studies. So on an individual level, what we are looking is that again the information that I want is that whether my sensitized patient is going to get a donor without without antagonizing epitopes against it, or I have multiple donors, just like we discussed today morning. Then the real choice between donors comes. So this is the recipient and donor HLA typing. So what we put is that we actually the computer gives you the epitopes when you just put your high resolution HLA typing into it. Okay, so you just put it into this thing. Put your recipient HLA and your donor HLA. Class 1 and class 2 is done separately, and we just put it into this thing immediately, spontaneously. They will give you that there is total 9 eplet mismatches between, just like if you remember the cartoon that I showed you, between these two patients at class 1 there are 9 eplet mismatches are there. Now I look at the antibody profile of that particular recipient. I know the patient is having a lot of antigens, antibodies against those recipients. Now what I would like to see that I know that there are 9 eplet mismatches. I'm just making it simple. So I just know that between these two patient and recipient there are 9 eplet mismatches. Now I have a lot of antibodies. Okay. Now the thing is that the new tools will help us to say that which also out of the patient has got many epitopes are mismatched, but only these 4 epitopes are accounting for all these and majority of these antibodies. Okay. So the thing is that when I select a donor, I should avoid a donor with at least these 4 epitopes. Okay, now I have the donor typing and I look whether these particular donors have any of these HLA. So it is just a cross-check mechanism. I know the epitopes which are mismatching. I know the antibodies. I'm just making sure this antibodies doesn't have a hostile epitope to it. So this is another thing. We have a lot of antibodies. Actually, this is another use, So when you look at the epitope load, many times it's like 66 epitopes are there, mismatching. But when you look at the real culprit is that just 4 epitopes are accounting for the most of this reactivity. So you have a lot of antibodies. So if you are going to avoid this antigen, this is another way of making it, saying it. But if you look at the epitope, it might not work every time like this thing, but in certain cases, okay, these 4 epitopes are the culprit epitopes. So these are tools that we can use. But if you ask me, do I use this thing? I very rarely use it. I use only when we are when in the circumstances of doing a paired kidney transplant, or when you have multiple donors. Just like in a paired kidney, you have to take it to he's the second transplant guy, he has cross-reactivity or all this thing. In that cases, we try to use it, but we don't have that much donor options in our country. So this is it. Now the second is, I told you on a registry level what this information is helpful. Okay, the thing is that we know that, so this has been the old, what we discussed today morning is that we look at the mismatches. You have the 3 antigen mismatch here, and this is the collaborative transplant study, the most updated international registry. So you see that the 0 mismatch does much better than 6. So the thing is that this the splaying of these lines or the demarcation is, you can appreciate only you have n number of patients. This data is like 250,000 patients. Okay, then only you are able to appreciate the effect of these HLA mismatches and matches. Okay, but if you take, if suppose Nizam every year they do 100 transplants. After 10 years, then look at 1,000 patients. I bet that if you put a 0 mismatch, 0 mismatch might be the one graph that might be up there, or I can bet that 1 to 6 mismatches, everything will be one line. Okay, we will not be able to appreciate the differences. Here's where the epitopes can help. Okay, so this is again the one advantage of the tool is that, just like as a discussion from what we had, this HLA typing is not going to change. So once you have in the system, you have this epitope data out there, it's always a piece of information. You can do any number of even 1,000 patients at the same time. That software. Okay. So here, this is one interesting paper which is actually which highlights the importance of DR and DQ, which highlights the importance of epitope matching and all. This is from Manitoba. So what they have found is that the same equation, when just looked at the mismatch from DR, 2 DRs and 2 DQs, you can have 0 to 4 mismatches. Okay. So when just by putting at the antigen mismatches, actually they are not able to differentiate between the 1 to 2 mismatch and 3 to 4 mismatch. Okay, DR0 mismatch is just like it is doing good. Okay, but the same thing that when they converted into the number of epitopes and their model, what they found is that more than 10 epitope mismatches actually did better than the lesser the mismatches, the better was the outcome. So this teasing out, this is just 600 patients, okay, and follow-up of 10 years, okay. So they are able to tease out, okay. The other, you have to have like 250,000 patients to have any meaningful outcome to see how the basic HLA typing or the epitopes behave among each other. Another important thing is that we traditionally believe that 1 mismatch is better than 2 mismatch, but that need not be. Okay, the study showed that there might be 1 mismatch patients with a high eplet misload, which might not do well. Okay, and 2 antigen mismatches might have a very low eplet mismatch load. So eplet mismatch will give a better correlate of clinical outcome. That is what these studies have shown. So just like what is the take-home message, or currently what we can do is that on an individual level, if you know that if a patient has a lot of antibodies and you have multiple donors, you can tease out between and select this. Okay, this donor might be better from an epitope standpoint. And other thing is that, if you have a large registry data or like in-center data, if you are able to pool all your data, then you can. So the advantage is that you at least know that, these patients have a low eplet mismatch load. And with the current evidence, I think we can initiate a dialogue with the recipient. Okay, if suppose there are multiple donors coming, you can say their antigen mismatches might not be that different, but we can initiate a dialogue. There is at least on retrospective studies, we have reasonable data to say that, okay, I think there is some advantage from a eplet standpoint, but you cannot accept or deny on based on the available evidence. But you can initiate a dialogue, and if there is a guy who is like, he really into it, who is understanding, he can Google it out and find, because there is a lot of data right now coming which says that less epileptic mismatch might have a better outcome. Now coming to the future, this is where, I mean, the only country that has forged ahead with the epitope matching is Canada, and it is only because the Genome Canada Transplant Consortium has taken the lead. So what they have done is that, this is the current scenario. We have more than 37,000 alleles right now, and it's still counting, okay? And so Canada that have what, Canada is a, multi-ethnic, multiracial community out there. So what they did was that they took, a broad-based sampling and did HLA typing of everybody, okay? And almost like 2,000 HLA typing was done, and more than 400 alleles were found between these two people. But interesting thing is that once they looked at the epitope number is less. So this 37,000 alleles might be like 200 epitopes, okay? So that is where we have a hope, okay? So what they found is that there's just class 1 there are only 59 epitopes, and class 2 just 90 epitopes. It is the different combinations of these epitopes that account for different alleles. So what they found is that when they are looking at the distribution of HLA antigens, you see that it is skewed. In one direction, one particular HLAs are dominating, other HLAs are you get like 1 or 2 people. So to have an HLA matching is theoretically difficult, because there are certain people who have got particular HLA and others are much less. So what they do is that they did the epitope. They looked how the epitope is being distributed in the population. So that was interesting. That was more even. Okay. So this is where we have some hope. So when you are looking at the epitope, there might be more chances finding an epitope match rather than a HLA match. So this is more even. So this is a good work going on. But again, it is a work in progress. And another thing that they did is they took their transplants in the last 10 years, and what they looked was that with the current matching system, they have this 0DR, this thing ABDR matching system and all. With the current system, their average transplant they are doing. So retrospectively, they looked at the epitope data of all these patients, and what they found is that currently they are the last 10 years data they have done with the epitope mismatch of 30. Now they did was that suppose these patients had been gone through a epitope matching. This is just an exercise that they did. Suppose proactively, prospectively they had undergone a epitope matching, and whether they had done a transplant, what they found out that they could have offered kidneys with just 10 epitope mismatch. So this is where there are a lot of hope, and some people are working on it, but only Canada has taken the lead. The last HLA international workshop was in Amsterdam. So the main focus was on epitope. Now the issue is that we don't know about it. It might not be the number. Now the Manitoba group more than 10, less than 10. In biology, number doesn't work. It might be certain epitopes might be more immunogenic. So the people are going to look into the qualitative aspect of the immunogenicity. And actually, this is an ongoing study. And basically they are recruiting patients. Any center can participate, okay? So what they want is that they should have naive patients, no HLA antibodies in their system. You get transplanted, you check antibodies, and finally 5-6 years down the line, we see that one cohort will have de novo antibodies, and other cohorts will not have any de novo antibodies, and you are looking at the epitope matching. Any center can participate. Value is there, I know. So to conclude, conceptually, I could justify many of these concepts. I think we all agree that it could be something in the right direction, but the framework is incomplete. We don't know. New epitopes are being identified, new alleles are being identified. So we don't know where this is going to end. Okay, and I think we can, just like I told you, it might be a quantitative. We can identify certain combinations of certain epitopes to be more. We can identify that might be helpful. But we need more information on that. And I don't know how Canada is going to do that, even if they have impressive data. But I think to start with, at least a high-risk population or a pediatric population would be a reasonable thing. That's my thought. In Indian context, I think as a forum, we all should agree that we should do HLA typing. In the grand scheme of things, you are paying around average 6 lakhs to 7 lakhs for a transplant, or like 3 lakhs. I think 20,000 one-time investment or 15,000 one-time investment I think patients won't say no to it. That's my view because I have been just like Shruti, I'm a mixture of both. So slowly when I'm convincing them, they are not saying there's no much hesitancy from them. But I find it more hesitancy from my nephrology colleagues. Another what are you going to do with this thing, information and all. But I think this is something you don't know what is there, in the future. And so a lot of work will have to be done and the information have to be done. So other day I was just, we had a discussion about BAMF classification in renal pathology, okay? It has been 30 years since pathology, BAMF has come up with different, every 2 years they used to meet and except for COVID, they did not meet in 2021. So in the first 1991 BAMF paper, they have mentioned 3 rejections, okay? Class 1, you can do, see if there is graft dysfunction, you can do. If it is class 2 rejection, you can give steroids or thymoglobulin, and class 3, it is very difficult to treat, might be patient graft loss. Okay, looking back, okay, class 3 we know it is antibody-mediated rejection and we have a lot of information on that. But pretty much not have changed in the last 30 years. So that was also interesting. In 1991 they wrote these things. So we have this genomic data coming, we have C4Ds coming and going. But so many times we might be landing up in flows and this thing. But this is a certain thing that is coming up for planning purpose. Thank my mentors and thank you all.
All of you should know he also has an excellent lab of his own in Kerala and he does a lot of work. I think this is for all of you. Why should we even do single antigen bead with HLA? We should have antigen beads with epitopes only. And then find out how they work. And sir can develop a flow also for them. There are only 48 templates you need, sir. Not so many of these, isn't it?
Yeah, I don't know where this is going to take, madam. But I think, to be frank, I don't know in brief, but I think at an individual level we should be looking into epitopes. But going into epitope matching is, I think, too far-fetched, madam. I don't know. But the thing is that as a clinician, I think, we all should agree that our job is to facilitate a transplant, madam. You know it better, right? So with all this information, if we are landing up denying a transplant or frightening the patient, that is the problem.
Actually frightening them because of the cross-reactive epitope groups.
Yeah. Actually, even in cross-reactive group, there are 2 schools of thought. There are people who call the cross-reactive group as a DSA. Okay, suppose I have the lowest B52 is like 1000 MFI. I have only mother as my donor. Okay, and class 1 is something. If the cross match is negative, you can ID Feroz Aziz or do something, and you deny him a transplant saying that you have an A2 crack with the B52 DSA low titer. We don't know. Even the old data that Shruti told, the Paris group data, only CDC data, 75% of patients made it 7 years.
No, but then again, if you go to Terasaki also,
yeah,
as it was discussed, 80%, 20% who were cross-match positive actually did well.
So we don't know. That is
Any questions?
Thank you, sir.